Afternoon, and Monday, of course, the 6th of April. And this is after the weekend, our first full week. I call it the post, the wind down of the travel impacts and that aspect there. We're going to hear some numbers today and see how we're doing. As I said, this week's an important one as we ease out of the period of time when we had a lot of people returning to Ontario, and I'll talk about that in a moment and how it's going to go. And then another aspect is later in the week, how well are our public health measures, our physical distancing doing? And I've been pleased when I've run around watching and stuff that people are doing that. They're adhering to that. We hear anecdotes that some people still are being casual, but I hear there was less issues over the weekend. And of course, some municipalities, such as Toronto, has taken steps to limit that. And they did so. I heard examples of where they had undertaken to tell people that those parks and areas were not open as people wanted to take part in the warmer weather on the weekend. So first, let's go over to the numbers for today, over to Dr. Yaffe. I'll let you cover those numbers, Dr. Yaffe.
Okay, thank you. So as of yesterday at 4 p.m., the numbers that have been input by the local health units into the Integrated Public Health Information System, we have a total of 4,347 confirmed cases of COVID-19 in Ontario, which represents an increase of 309 from the previous day. About 35% of the cases are in people 60 years of age and older, and 52% of the cases are in people who live in the Greater Toronto Area. Of all the cases, about 20% had traveled in the 14 days prior to becoming ill, 13% had a close contact with a case, 19% had community exposure, and about 48% the exposure information is still pending. At this point, unfortunately, there are 132 cases that have passed away, and we have at least 46 outbreaks in long-term care facilities involving 56 deaths, some of which were lab confirmed, others not. We are at about 1,624 resolved cases, which is going up. It's about almost 40% of our cases at this point. We also know that at this point we have currently 589 patients with COVID-19 currently in hospital in Ontario. Of those, 216 are in ICU, and of the 216, 160 are on a ventilator. In terms of lab testing, we have, as you know, basically gotten rid of the backlog. We have tested almost 79,000 people in Ontario. Currently, 329 are under investigation. In the last 24 hours, we've processed about 3,500 people's tests. Turn it back to Dr. Williams.
Right. Well, thank you. And a couple of things I'm looking at here as we move into this time. You'll notice that some of the data we're utilizing at this time, we talk about cumulative hospitalization, and that's going way back to January. And after a while, that total becomes less meaningful, and we're looking at how do we get some more, as we're changing some of the data points, how many currently are in the hospital, how many have been discharged, and all those aspects there. So we continue to watch that as we progress in this phase of the outbreak. And so that's one aspect there. I noticed that today, of course, we've dropped down to just over 300, and that is our lowest almost in a week and a bit over a week. As we had moved up, for your memory, last time we were down below that was back on March 31st, and then we climbed up to highs of 426 and 462, and then petered around that at the top end of the upper threes and the 4, and now we're down to 309. So the question is, how does that relate to our other activities? There was some peak times I expected to see with our travel drop, is that we'd stayed at fairly high numbers up until about 2 weeks ago from basically tomorrow, and Wednesday, then it dropped down one step, and then by Thursday we dropped down another step. So 2 weeks back from this Thursday. So it'll be interesting to see how our numbers progress as the week goes on in that regard. There. And the other aspects is that we continue to work with our federal authorities, assessing the new information, especially related to various cases with ideas and concepts around so-called transmission, or at least positivity in cases of people who are deemed to be asymptomatic. They found on some large studies that, well, people had been found to be had the presence of the organism in their PCR in their nasal pharynx during that time. When they asked those people more details, 75% of those that are asymptomatic actually found, they said, well, I guess I was. I just didn't think about it. And so there's that aspect of, is it truly asymptomatic or just so low that people didn't think too much about it? And then we have some aspects around pre-symptomatic in periods there where people, it has been found, but how infectious are they at that time? And while there's a potential to be infectious, it was deemed to be less than when they peak time just before they became symptomatic in the so-called prodrome immediately before, and their viremic. So it's a long phrase for when the virus had reached its peak in their body, and they were deemed to be much more infectious at that time. So we're learning more about this all the time and being informed by that of how we might address our policies and principles in that regard. As we continue our social distancing, people prefer the physical distancing term, and our other measures that we put in place. Now we have some even further reduction in essential businesses, and how is that going to impact us in that regard, as people are doing various things to, I guess, to adjust to that status of how to continue that on the next week or two as we go forward, and monitor how well we are doing in our numbers as we progress there. Furthermore, the data that we're continually feeding into our modeling, and that was, remember, last Friday, in that, and to see how that is impacting those numbers in there. And even now, just reflecting of where we were at that time when they reported, like last, it was data based from last Wednesday and Thursday. By now, we should have been double that with over 5,000 cases, and we haven't. So maybe that is reassuring that we are continuing to bend the curve and to make an impact, but we want to make sure we get the right numbers to them so they can revisit and refine their predictions, as they said in the press conference, based on receiving real-time data and how that informs them accordingly. So with that, I'm going to open up for questions from people on the line.
Sure, we'll take the first question.
Your first question comes from Lisa Zing with CBC. Please go ahead.
Hi there, doctors. Sorry about that. I forgot to unmute myself. My first question is about Telehealth Ontario. At first, you've said people should call telehealth to get advice if they have COVID symptoms. And earlier today, Health Minister Christine Elliott suggested that people should actually be calling their family doctors now for faster service. So can you clarify what people should be doing at this stage to get answers?
Sure. When we started off, we had telehealth, and we were dealing with a large load where the average calls in a day went from the mid 4 to 7,000 up to over 20,000 in a period of time, because that was our most available tool at that time to respond to that. And then as we progressed along, we added the self-assessment tool, as you recall, and that has over nearly 1.5 million hits on that one, and it continues to be well utilized. Following that, we did introduce, in consultation with the OMA, the different fee codes that would allow physicians to do phone call, virtual consultations, if you may, and to handle that. As a result, a number of them made it available in their practice placements, whether it's in a family practice, a health team, different formats, that they would have someone available to take calls and to answer questions and concerns from some of their patients. And of course, they would be even better prepared, because they would have often the chart electronically in front of them to be able to converse with that member or the person who is part of their practice and could answer that in a timely fashion. So that was added there. And that's why I think the minister was saying during this time as well, call your primary care physician, because they're there, they're available, they're ready to receive those calls, and they could give you advice on more on your own actual perspective, because they actually have access to your chart and different details that would make it even more, I would say, refined than you would get at telehealth. Telehealth is still available. And for people who don't have a primary care physician or are having trouble reaching in some cases, then call telehealth. It still has a good place to call for advice and direction. Same as the self-assessment tool. And they, of course, are segueing into the assessment centers, now nearly 100 in the province of Ontario. So there's many ways and venues for those who feel they might have symptoms of COVID or concerned if they have symptoms of COVID or just want to have some further information to understand, family members they want to ask about. So there's many sources that you can go to, and you should access those when you need them and in the way that you're most comfortable to do so. So it's been an evolving story, a good one in a way, because we really ramped up all the different ways that our public can approach. And we've seen the numbers in telehealth come down. The self-assessment hits come down. I'm not sure yet. We haven't got the metrics on the physician calls at this stage, but they have, of course, increased over the time when they come on board. So I think a lot of people have had a number of their questions answered, and we're hoping that they feel it is done in a timely way, in a way that answers their concerns and gives them advice and direction that's appropriate at all times and helps to segue them into further testing and care as necessary.
Follow-up?
Thanks very much. My follow-up is about testing in long-term care homes. In terms of limiting the spread in those homes, have you given more thought? Is there more discussion to more widespread testing if we know that asymptomatic people carry the disease, but right now only symptomatic folks are being tested? So how are these homes supposed to properly isolate people who may be transmitting the disease who don't have symptoms?
Dr. Yaffe?
Yeah, certainly that the long-term care population is a very vulnerable population, very high risk if the infection is introduced into the long-term care home. So, of course, the most important thing is to try and prevent it from coming in, which is the importance around not having visitors except in, important compassionate circumstances. Screening everybody coming in, all the staff, twice a day, including temperature. Screening the residents twice a day, including temperature. But you're right. Once we have any suspect, any suspicion of symptoms, the first thing is to test that person, isolate them, and test anyone else who's symptomatic. We are looking at the testing criteria. And one of the things that's happening right now is, in fact, there's a group of experts looking at, now that the testing capacity has gone up, we want to expand who's tested, but in a way that's controlled so we don't end up with a backlog. And this is one of the high priority populations, and consideration of potentially testing people who are close to the case, who are asymptomatic, people around them. People who work, the residents who share a room with them or share dining space, or people who worked with them, the staff. So that is certainly one of the areas we're seriously looking at now.
Next question.
Your next question comes from Allison Jones with the Canadian Press. Please go ahead.
Hi, Dr. Williams. You touched on this a bit already, but I'm hoping you can expand on it. You mentioned the number of new cases, just over 300. It also says on the website that it's about a 7.7% increase over yesterday, which is the lowest percentage I remember seeing in quite a while. Can we read anything into that, or is a one-day relatively low percentage just too little to read anything into?
Well, yes, and we'd like to be optimistic and to see if this is a trend. As I was trying to give a sense there, the numbers over the last week, it rose up on the 31st. It stayed and plateaued around the middle of the week, around the mid and 400s and upper 300s in there. And we had 408 on Sunday and then 309 today, which are results from yesterday, by the way. So, so I'd like to be encouraged, but you're correct. One day is only one day, and there's lab test flow and different things that happen. So I would not be jumping to any conclusions at this stage because, as I said in and looking at the amount of travel people back in the 2-week period before, we didn't have a major drop that would affect it until maybe in the next day or so. But we want to test that, and of course, we want to continue to monitor how well our public health measures are doing and how, like a report card back on ourselves, if we're having success, as the modelers had hoped for, to continue bending the curve even more.
Follow up?
I just wanted to confirm, Dr. Yaffe had said that gave a number of 589 patients with COVID-19 currently in hospital. But then, Dr. Williams, you talked about cumulative totals. So I just want to be sure, is 589 the number of people who are right now in hospital with COVID-19, or is that the cumulative total?
According to the data I have, that is the number of people currently in hospital with COVID-19. Now, keeping in mind that people probably will be in hospital for a period of time, so this isn't necessarily people, recently admitted. We don't have at this point yet, but we will, I guess, more of a daily number, hopefully. How many are admitted? How many are discharged?
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi there, doctors. Just my usual question. What's the number right now on healthcare workers that are infected with COVID-19?
That number there, Dr. Yaffe, if you do.
I have it somewhere.
In the back there. I know the last time I had it was around 239. Cumulative again. And even in the data there with the 589 on one chart, it says it's cumulative since January with the hospital patients. And I'm just trying to see if that number has risen above the 239. And I don't have that data piece in front of me, Rob, at the moment. It was, yes, the other day it was 239, but I think that has been updated accordingly. So about 451. So that was, my 239 was a week ago.
I found it.
Oh, you found it.
451.
Yes, 451.
It's usually around roughly 10% of the total.
And that's cumulative, of course, since January.
Yeah.
Follow up?
Know if any of those are hospitalized or in ICU? What's the status of all those?
Oh,
That data we don't get. And I know of different ones that were hospitalized for a while and discharged in and out, but we don't get that broken down, because when you say healthcare workers, that is their profession. Now, they may have gotten it following return from travel and been in isolation at home in there. We'd like to get some more breakdown, or any related to the more concerning side. Did they get it from what we call the word nosocomial, or infection in the hospital while on duty? And then we're trying to see if we can segment that data to understand that in there. As for how many were in ICU or ventilation, no, we don't have that data, Rob.
Next question.
Your next question comes from David Haynes with Queen's Park Briefing. Please go ahead.
Hi there, doctor. To focus on the bed capacity, the modeling that came out on Friday showed that in the best case scenario, the province would be near capacity, but would have enough. But it's unlikely that capacity will be evenly distributed throughout the province. Are there parts of the province that you're looking at as being at particularly high risk of being over capacity? Is that based on them having higher rates of infection right now, or on demographics and so on?
So I'm going to see if I got all the question. You're a bit faint there. I think you're talking about hospitalization and the modeling saying that we would be at capacity in certain areas of the province at different times. And I think if I got it correct, and you have to correct me, is that you were saying, does that depend on the demographics or high-risk populations that the different areas might be dealing with, or not? Did I get that correct?
Yeah, that are there particular regions of the province that you are concerned about more than others based on how many positive tests they have right now, and the types of demographics for those regions of the province?
Well, what we're finding is that most of our cases are in the GTA, between the larger areas like Toronto and Peel and York, Durham, and out around there, which have the most, of course, hospital facilities, isolation rooms, and ICU beds and ventilators. So, in that sense, they're the ones that are seeing quite a few. Some of them have more load than each other, and there's no need yet, that I've heard yet, of shifting and moving in that, because not everybody gets the person admitted at that time. While there's a 6% hospitalization, it doesn't mean it's going to be equally divided. It depends on the individuals and who have the misfortune of having more serious sequelae of the infection requiring hospitalization, and then unfortunately ICU and ventilation. I think the more concerning ones out in the areas out further, when you may have regional areas that have less capacity in that sense, and if you get a large hit in population or in cases, and with some have very much a number of retirees and older age groups that may have more risk of more severe consequences. So we try to watch that very carefully, and that's why we have our regional committees of OH set up that looks at that data, looks at the hospital usage, what isolation rooms they have, ICUs, vents, and how much they relate to the long-term care facilities and the retirement homes and other facilities they could use to offload all of a sudden surges if it did occur. And of course, if it was extensive, they would have to offload to other regions around, and that's part of the value of the command team, as well as having the regional tables that try to solve it within the region, and then they can go outside to seek. So it's right now everybody is coping and doing well at that time. The hospital, because of the rollback in the elective surgery, some at an all-time low in almost 15 years in that. So building up that capacity to deal with the surge if and when it does occur. And we are seeing increased numbers, as Dr. Yaffe has alluded to, and that's not surprising because, as I said in our data, we just went through a week of having numbers up in the, for the first time, in the 400s of new cases. And if the hospitalization rate is at the 6% rate and then the ICU rate at the 2 to 3% rate, then we'll see an appropriate surge in that level as well. The challenge being is that sometimes those admitted to the ICUs and that don't just stay for a few days. Some unfortunately have to be in there for an extended period of time, and that means that the occupancy increases disproportionately, if you may.
Follow up?
So when you're talking about a shift in capacity from one region to another, because one region might be harder hit than the one next door, and so on, do you have an idea of how quickly that can be turned around? Is that something that resources can be significantly shifted from one place to another in hours, or in 2 days, say?
Well, good questions on scenarios. It depends on some of the facilities. If they have room for more ventilators, they can be moved over there. You have to bring the staffing and some of them with it accordingly to make sure they can move from one facility to another to handle those loads. There's others where you may have, if we're very critical patients or that come on very quickly, you may choose to use Orange and that to move them to a more tertiary care center for that time period as well. So there's that flexibility using your various services for patient transfers. Orange, for example, on that if it's really from a far distance that needs to be handled. So there's many strategies that can be undertaken, and that's why there's no cookie cutter approach. It depends on the circumstances, and that's why the advantage of having all the players at each of the regional table to put their best minds to the task, and then they can merge into the federal or in the whole province-wide command table to see how we would orchestrate and to assist in moving resources accordingly.
Next question.
Your next question comes from Justin Urcelli with Yes TV. Please go ahead.
Hi, Doctor. How are you?
Thank you.
I have a question. So, do you think we've reached our peak in Ontario with the numbers today?
Well, I guess we're all looking for that, aren't we? And I'd like to be able to say that with confidence. I I said that we peaked earlier in the week in the upper 400s. We were still doing with lab backlog, new labs coming on board, testing capacity, and as Dr. Yaffe said, we've removed that backlog now, so we're getting much more real time, if you may. So some of that large amount may have been due to backlog numbers, so we may have been in more like the low 400s in there. And so, as the other reporter had asked about, with this now dropping down to 309, we haven't been below 300 in over 7 days, 8 days. A bit early to make that conclusion. Now that we stabilize the testing, now the other thing is that as we do more tests, it'll change it again. So we have to make sure we don't mix that into it. If we do a lot more testing with, as Dr. Yaffe alluded, with our outbreaks in our long-term care facilities, and as our lab and surveillance group are looking at other strategies to utilize this capacity to give us even better data or wider data, of which the modelers are asking for. And so we're trying to do that and to keep meeting all the different priority groups. So I'm just trying to prepare you to say, well, I'm going to get some numbers coming back in the next 3 or 4 days. It may be merged in with a new enhanced wider testing, which is good. So we're going to have to be able to segment that. And to answer your question on the wider basis, have we plateaued, at least on the travel related issues? Because as Dr. Yaffe alluded to, the ones that are related to travel, that percentage continues to ease down from, it was in the mid 20s down to under 20%, heading down to even lower. So in the future, you'd have to say, if the borders have closed and everything, there should be hardly anyone related to travel, but case contacts and others. So we're looking at that as well. So that's a long answer to say I'd like to think so, but let's stay tuned.
Follow up?
My follow-up is, what do the numbers have to be for, the state of emergency to be lifted and for gyms and bars, schools and all that to reopen?
That is a big part of what I've been trying to look at. Actually, when we start in this one, I want to be clear on what we do when we ramp up. Our public health measures working group or table, headed by the former medical officer of health for Toronto, Dr. David McEwen, is looking at that issue as well, to say in the fact when you see the numbers are improving, because we would like to think about when you can start turning that dial back, as we use that allegory. And we found out in the past, I said, if you just flip it back very fast, you often have to retrace your steps, and that would be most disappointing. So we want to know that when can we roll back some aspects to help people to adjust and to return to some other areas of especially necessary functionality without violating totally some of our distancing aspects. So we're having a group look at that right now, and so that if and when that time comes, we hope to be able to give some direction to the Minister of Health and to the Premier and Cabinet of when they might want to change and ease. As always, they're looking for recommendations from myself and from all the ones who would give advice on that regard. So we're looking at that very intensely right now.
Okay, we're going to move on. This is going to be our last caller.
Your next question comes from Kenyon Wallace with the Toronto Star. Please go ahead.
Hi, doctors. Thanks so much for taking my call. I just have a question again about testing numbers, and that is, we spoke last week about how we were going to have expanded capacity now in Ontario, and I assume that we do because we've been able to eliminate most of that backlog. So my question is, how come we don't have as many, if we have all this capacity, how come we don't have that many tests? How come we're not doing that many tests? Is it that they're just not coming in from hospitals and assessment centers?
So, as I mentioned earlier, there is a group that's been struck of experts that's been meeting very intensively over the weekend and now in the next day or two to come up with priority groups for testing given the increased capacity. Because we didn't want to just say, go ahead and test everybody that you know, with symptoms or without symptoms for that matter, because we'd end up with a backlog immediately and back to square one. So once we get the strategies approved then we will communicate out to the field. And for example, we know long-term care is a high priority, healthcare workers and so on. But we know we can expand. We just need to come up with the specific groups and how to do it, and that will be communicated out very quickly. But in the meantime, I would say the assessment centers are aware that there's increased capacity, and we are certainly saying, if you're concerned about this person, please do test them.
Yeah. If there's been any kind of thought on expanding, I know you mentioned this expert group is coming up with something. Do you know if there's been any talk about opening this to more like surveillance testing, where we test lots of people to get a sense of the disease's prevalence in the general population?
Well, we already do sentinel testing of people who are seeing a family, sample of family doctors for influenza-like illness. We get them tested for COVID-19. And in fact, that's how we picked up some of the outbreaks in long-term care facilities through the sentinel testing. We also have a system called ACES, which looks at the trends in COVID, suspect COVID patients coming through emergency departments. So certainly that's part of what we're doing, and we are always looking at how we can do better on that as well.
Unfortunately, that's all we have time for today. Thank you.